Welcome to the Expert Roundtable podcast, where we connect frontline clinicians with top thought leaders to facilitate discussion on key issues they face daily.
This is your host, Tom Urochi, and today's topic is CSU, or chronic spontaneous urticaria. There's two things. It's chronic, it comes and goes for weeks, months, or even years, and the urticaria and the angioedema. And then it can be spontaneous, which tends to bewilder people because there's no clear allergens or triggers involved. And this combination of the two, the chronicity and the spontaneity, can be quite unsettling. So today's guests are all expert in this area, and let's hear from them. Let's do some introductions here. Dr. Friedman, do you want to introduce yourself?
Sure. Hi, everyone. Dr. Adam Friedman. I'm professor and chair of dermatology at GW. And I'm excited that we're talking about CSU because I feel like, at least in dermatology, it's kind of like the ugly stepchild. No one wanted to deal with it. They didn't want to welcome the patients in. And finally, we're open in our arms. But I know my colleagues have been dealing with this for quite some time. And so I'm excited to share this podcast with them and share our ideas and kind of figure out the best way to approach this condition for the foreseeable future.
Great. And Dr. Casale?
Hi, I'm Dr. Tom Casale. I'm at the University of South Florida in Tampa. I'm a professor of medicine there and run the clinical and translational research in allergy immunology. And like Adam, I'm excited in part because of, a few years ago, we weren't talking much about urticaria and new treatments. And now, last time I looked a couple of weeks ago, I found 24 drugs in clinical trials for urticaria. So there's a lot of interest and a lot of activity going on.
Wonderful. And last but certainly not least, Dr. Bernstein.
Thank you. Jonathan Bernstein. I'm a professor of medicine at the University of Cincinnati and partner of Advanced Allergy Services. Certainly, as my colleagues have already said, that hives, urticaria are now really have really advanced because of novel therapeutics that we can treat our patients with. We now have really very good guidelines, evidence-based guidelines on how to approach this condition. And I think most importantly, we're shortening the patient's journey from the time they were diagnosed to the time they're well controlled, and we minimize their the health burden that this disease has on this population.
Wonderful. You just teed us up perfectly for the title of this podcast, which is Visualizing Success in Chronic Spontaneous Urticaria. And let's dive in. The focus question here is really, what are the current standards for diagnosis and treatment, and what does success look like? What should it look like? And where do we hope to go in the future? So who would like to start with this one?
I'm happy to jump in. I like to just kind of acknowledge our colleague, Dr. Marcus Maurer, and his message to us was, we treat until the hives are gone. And so patients shouldn't have to walk around with a few hives here and a few hives there. So our objective is to control the disease like any other chronic illness. And so we have definite advancements in our approach, algorithms, and how we should evaluate and treat patients. And it is, as much as we can, given the amount of literature, amount of research, it's evidence-based. So we would like to encourage our colleagues to really follow these algorithmic steps in terms of evaluation and understanding, is it hives? Are they evanescent? Do they come and go? Do they, are there wheals and is there erythema, redness, and so forth? So, and then, what are the treatments? And I'll let my other colleagues discuss that, but I just really think that our goal should be high, and it's not one size fits all. Hives are complex. There's many subtypes of hives, and some are responsive to conventional therapies and others aren't. So we have to be aware of that, and we have to guide our colleagues on how to evaluate patients in this manner.
Yeah, I want to echo the treat to clearance. And as dermatologists, we're no strangers to that call to action. We heard that from the National Psoriasis Foundation. we do not treat to 75% clear, we treat to 100% clearance, and we have to be creative with respect to how we do so. And the same should be true for chronic spontaneous urticaria. I think the title of this podcast, the visualizing success, is an interesting one, because one of the struggles, I think, is actually visualizing disease. Often for me, when patients come in, they'll say, if you weren't so busy, I could have come in last week, you would have seen it all over me, but now it's gone. And I think that ephemeral nature, the kind of spontaneity of it, you go from 0 to 60 in milliseconds, and then seconds later could be all gone, matched with also from a diagnostic standpoint, how it's an invisible dermatosis when they have an appointment. It's an invisible dermatosis even on histology. There's nothing really there. Speaks to, I think, some of the burden of being able to actually capture it and see what it is, but also to help patients understand what it is not, and why we shouldn't do the $1 million workup. Why we do not try to go after that root cause when we're talking about chronic spontaneous urticaria, because there isn't one. So we have our work cut out for us in terms of just even thinking about how to standardize the diagnostic approach, which is going to be a clinical one. It's going to be asking the right questions the right way, but then also educating our patients and our peers to ensure that we have that we're on the same playing field when it comes to understanding what the disease, what it's not, and then how we manage it.
I agree with everything that's been said, but the only thing I'll add is that because of the fact that these urticarial lesions can affect body areas that are visible, it provides an opportunity for us as clinicians that treat patients with urticaria to really help them and improve their quality of life. You could imagine that one day you could be completely clear, and here you are going out on a date, or you have a wedding, or you have something else going on, and all of a sudden you have hives every place. And I think it's very important for us to also share decision-making with the patient as to what their goals are, because I think we're at a point where we can treat to 0 symptoms, but we also have to balance that with how much does it cost to get there in regards to the therapies, potential side effects of some of the agents that are used, and work with our patients to achieve the best outcome for them.
Yeah, I want to echo something you said in terms of that unique spontaneity of this disease, in that, one moment you're clear, the next you could be covered head to toe. Nothing else in dermatology does that. And so that never knowing when that next shoe is going to drop and hit the floor hard makes this a uniquely burdensome disease. Nothing else does that, where it can come out of nowhere. There's no warning sign, and I think that really limits the quality of life of those suffering with it.
Yeah, and I would agree, but I always tell patients, as I'm sure you all do, is a picture tells 1,000 words. Take pictures. Everyone's got cell phones, just show it to us, and so we get a good assessment. And I think the other point we have to make is that a lot of these patients, maybe up to 25 to 30%, might have inducible forms of hives, and these are triggered by physical stimuli. So there are, in some cases, triggers that we should be aware of, and so that's part of the differential. And we know that if they do have an inducible component, that these hives can be much more protracted and sometimes much more challenging to manage.
And also, I think, unfortunately, we still have to reiterate that sedating antihistamines are not the first-line therapy for this. We still see this all the time because they're readily available over the counter, but they're also still prescribed by a lot of primary care physicians. And there's no reason to do that, because the second generation or non-sedating work as well or better than the first generation. And that also will improve their quality of life. There's nothing worse than a patient coming in and just got in a car accident because they were on a sedating antihistamine. I've seen that, unfortunately. So we have to stress that we have better therapies now, and we need to make sure that they're on treatment that improves them but doesn't cause any adverse effects.
Which brings us to what is the algorithmic approach for the treatment of urticaria. And and how do we approach this problem? And I think that one would say that the first line treatment is non-sedating second generation antihistamines, which there are several over-the-counter antihistamines. I think there's only one that's still prescription, desloratadine, but we recommend that patients, when they're started on treatment, that they're started on one of these agents, and that it can be advanced to up to 4 times the recommended dose without issues. I'd like to get Dr. Casale and Dr. Friedman's approach, what their opinion is on this.
Yeah, I think it's important to note for dermatologists, because we're used to, especially with systemic therapies, educating patients on it takes time to work. So when we think about oral therapies for even acne vulgaris, most common inflammatory skin disease, biologics for psoriasis, we're looking down the road in terms of seeing positive outcomes. But in this case, to your point, we do rapid dose escalation because it's going to work quickly. And so that's where I definitely lean more on the European guidelines in terms of dose escalation. I'm at that 4-fold recommended dose within 3 to 4 weeks from the moment they walk in the door. Thankfully for electronic medical records, they can keep me in the loop with how they're doing in a secure manner rather than bringing them back very quickly. But by 4 weeks in, if they're on 4 times that dose and they are not effectively controlled, we're moving to the next line, which now would be either omalizumab or dupilumab, in my opinion. But I think the key is this is not a marathon; it's a sprint, at least early, when you're dose escalating.
I think the important point that you made, Adam, is that if people are going to respond, they do respond very quickly, and there's no sense in waiting. We'll see you back in 6 weeks, see how you're doing. I mean, it's like dose escalation. Almost everybody comes in on some antihistamine. So you could immediately, if they're on a licensed dose of an antihistamine, immediately try 2-fold and then go up to 4-fold. The only thing I do caution some of my patients about is that certain of these second generation antihistamines at 4-fold the dose, you can get some sedation and impairment, much less than first generation, but it's good to remind patients about that. And then we know that about half of the patients, despite 4-fold licensed doses, will still have significant urticaria. And at that point, we do go to the biologics. And fortunately, now we have 2 available, and many more, I think, will be coming down the line.
So the guidelines currently recommend limited diagnostic testing, and typically a test might include a CBC, a complete blood count with differential, maybe a CRP or a SED rate, but I would lean towards a CRP, and possibly a TSH or something of that nature. Now, the way those were recommended, I think, in the past is not what we think about those types of tests in the present time, because they can provide us potentially with some information that is still controversial, but may be helpful in predicting responses to certain treatments. For instance, some have suggested that CRPs, high CRPs patients may not be as responsive to these second generation antihistamines. And similarly, in a second line type of diagnostic testing, other biomarkers have been proposed that could potentially predict response to some of the biologics you mentioned. I'd like to get an idea of what you all think about select numbers of biomarkers like thyroid peroxidase, like a total IgE, a CRP, and such. And of course, we get the eosinophil counts and basophil counts in a CBC. And do you utilize those in your algorithmic approach, or at least in your discussions with patients about expectations, what they might expect in terms of treatment responses and down the line?
Yeah, I mean, from my perspective, less is best. Unfortunately, we don't have very good predictive biomarkers. Now, if I am going to start somebody on omalizumab, I might do an IgE level with the idea that if their IgE level is very low, then they're more likely to take longer to respond, or perhaps not respond as well. And that's good to know, because if you're talking to a patient, you could provide realistic expectations for them. However, if their IgE is very high or they have IgE against TPO, these are the people that are going to respond very rapidly to omalizumab. Dupilumab, the only other biologic currently approved, has been shown to be effective regardless of the IgE level, BMI, or some of the things that have been shown with omalizumab to perhaps indicate a more delayed or a less vigorous response.
Yeah, certainly these were all of these studies were done in the context of antihistamines and omalizumab, and really others have gone and assessed their drugs to see if there was any effect. And as we're evolving into some of these novel therapies, these novel pathways, the utility of these biomarkers will probably become less to not important at all. I would caution that, perhaps with omalizumab, IgG antibodies against TPO have been shown to be good predictors of more of a type 2 autoimmune, type 2B autoimmune urticaria, and those patients do not respond as well to omalizumab. Only up to 45% of patients have complete response, and then maybe 40% have a partial response, which we've already talked about is not satisfactory. So if we're really shooting high, have high expectations. Your thoughts, Adam?
Yeah, no, my kids just saw Hamilton for like the 50th time this weekend, and so I'm going to harness Aaron Burr. Lab less, talk more. Clinical diagnosis. It would be beautiful if we had a biomarker that would predict what flavor of CSU you have. On the other end, wouldn't it be great if we had a biomarker that could predict whether someone is going to peter out? Like, we say on average the disease can last up to 5 years. We really don't know. And so just like our atopic dermatitis patients, you get these patients clear, and the next thing they say is, when can I get off my medication? And you're like, well, did you miss the chronic part of the name of the disease? But we don't know. So I would love to not just see tests that are actually purposeful and not just kind of broad and don't really give us information that will help direct what treatment we select, which we will hopefully have many, but also, can we predict whether someone can actually get off therapy or reduce therapy? But we are so far away from that at this point.
So when you think about our treatment of hives, we haven't had a lot of options beyond omalizumab, and now more recently Dupilumab, which in clinical trials showed that it was effective, but not necessarily more effective than omalizumab. But again, there are nuances, I'm sure, to that. But what do you think about the novel therapies that are coming to the forefront, and some will be approved probably very shortly? What do you think about that, Tom?
Well, I think the one that's going to be approved probably this year is remibrutinib, which is a BTK inhibitor. And that probably has at least 2 ways that it would work in chronic urticaria. First, we know the importance of IgE signaling, whether it's through an allergen or an autoantibody, in inducing mast cell degranulation. And BTK is one of the transcription factors important in that signaling event. So blocking it inhibits mast cell degranulation. But as Jonathan mentioned, we also know that there are a number of autoantibodies involved in CSU, and BTK affects B cells and the production of these autoantibodies. So it's a 2-for, if you would. Now, the advantage of BTK is going to be that it appears to work quicker than the other drugs, although we have to say that the caveat for that, we haven't done head-to-head trials exactly to look at that, but it appears to work quicker. It works regardless of the IgE or IgG autoantibodies, regardless of body weight, etc. So, and then finally, it's an oral drug, and some people don't like injections, but you have to take it twice a day. But I think the data look very good with remibrutinib.
So I'm really excited, and of course we have more biologics coming. I think it's always a good sign when you see one of those figures in a review paper where you see all the different cells and factors involved, and there are little lines with X's, and there are acronyms of drugs that don't have names yet. we're seeing that finally with CSU. It's not just like mast cell X and that's it, because it's not just about the mast cell. So I'm really excited that we do have a pipeline, and we're gonna, within probably a year span, have 2 new options in our therapeutic war chest, which I think will do quite a lot for us.
Yeah, I agree. And going to your point about blocking multiple pathways, I mean, there is a trend towards doing bispecific antibodies. And there is one that's in development that blocks TSLP that we think is upstream alarmin that could be important, but also blocks stem cell factor. So here you have a molecule that would inhibit the overall T2 inflammatory pathways and cause mast cells to die, hopefully.
Yeah, and of course we're close with the c-KIT inhibitors. A lot of side effects, but the benefits, we always have to assess benefits and risks in these patients. And then what I'm excited about, which really targeting non-IgE mediated pathways, are the MRGPRX2 receptors. And of course, there's one in clinical trials still that looks very promising, and of course has some ways to go before there will be approval. But I think the future is really bright in terms of treatment options. And we took a very, elusive, difficult to manage condition, and now we really have, we should be able to control, I think, most of the patients that we see with this condition.
So I sort of have my favorite things that I'm looking forward to seeing down the line. But Adam, what's the mechanism or the molecule that you think is going to make or break the treatment of urticaria coming down the line?
Oh, I think it's not going to be just one, to be perfectly honest. I think that somebody talk about, we've been so focused on the high affinity of FC epsilon receptor, IgE mediated, but the mast cell is littered with cell surface receptors. There are a lot of ways to skin a mast cell. And so I think it's going to be combination therapies. I just don't see how you could knock everything out with one blow. But to your point about having these dual action biologics, which we are seeing come out for atopic dermatitis, we're also going to see it for psoriasis in dermatology. That probably will be the way to go, to hit more than one thing at a time. But I think the fact that we can even ask that question right now is so incredibly impactful, because we tried to, if you asked me that 5 years ago, I'd kind of laugh. Like, what innovation? What am I excited about? There wasn't a whole lot, at least that we were aware of. So I think it is really an exciting time.
I do want to put a plug in for the guidelines, the Joint Task Force guidelines that are coming out towards the end of the year, which will really, it's evidence-based, at least, and it will, which really synthesize all the data out there and try to provide really good direction in terms of what we can expect from some of these agents. And it will include some of these yet to be approved agents like remibrutinib and some of the other novel therapies. But the future is bright.
Thank you so much. I think the vision and sort of all the recent developments in the field are going to be interesting for clinicians and providers of all different types, as well as their patients. And for more on CSU and many other medical conditions organized by disease state, please visit us online at expertperspectives.com. Thank you.